My objectives for this talk would be that I'll go over the prevalence and then outcomes after stroke, and then factors that predispose patients to stroke. But more importantly, and I did this earlier this year also, I'll go over some of the major trials that compare different device types and what do these trials have to tell us about the stroke rates. And so the major ones that we'll go over is basically the endurance, the momentum 3. I'll talk about the lateral, and we'll talk about the UK registry because kind of gives us a different perspective about how things are done differently in different countries. And then, of course, there's data from the Intermax registry. And then towards the end, I've tried to pull some studies that were done after the trials were completed to kind of compare HVAD, HeartMate 3, and HeartMate 2. And as I go through the trials, you'll realize that there are studies that compare HeartMate 3 and HeartMate 2, and there are studies that compare HVAD and HeartMate 2, but there is definitely no direct comparison between HVAD and HeartMate 3 for reasons that probably are more to do with device companies and who's going to pay for them, as you know that HeartMate 3 and HVAD are from different companies. So the reported incidence of stroke among patients who receive LVADs in epi years, which is events per patient year, is basically dependent on the type of device. And there will be different numbers thrown at us, but it kind of makes sense to talk about it in events per year, particularly for this outcome, because if you look at just studies, they talk about it in percentages, or if you talk about it in percentages, you have to understand that we cannot compare these percentages across the trials. And the reason for that is that the N, or the denominator, for these studies are very variable. And I'll kind of go over that as I talk about these trials in detail. And the epi, in epi years, it's 0.08 to 0.29. If you have 0.29, that means more high risk of stroke. Now in LVAD, one of the things that we have to understand is that we'll only realize they're having a stroke when they're symptomatic and you can truly see it on a CT scan. But there's a lot of times where, as we cannot do an MRIs on these patients, we won't be able to know if they've had subclinical strokes. So to say if you had an N of 100 and you have 100 patients and you say that out of them 20 had strokes, that number there could also be fluid, because the remaining 80 out of them, some could have had strokes, but we just don't know them because we don't see them on MRIs and they're not clinically manifest. They may have symptoms which were not very obvious. So in essence, there is a fatal flaw right there. But it seems that with that, we rely more on which are strokes that are fatal or disabling, and some people are of the opinion that it's the disabling strokes that matter. I'm of the opinion that any stroke matters, and I'll tell you why. And the reason for that is that any type of stroke can actually eventually affect your outcome and survival, and that has been shown across multiple studies. And that's one thing that is consistent across studies, that if you have any type of strokes, may it be a minor stroke that was not clinically meaningful, still portends poor prognosis in patients who have had strokes. Now, the issue with the multiple clinical trial is that they have varying study populations. There's different event definitions that are used. So unfortunately, I guess we never planned it right from the beginning, because from endurance to lateral, everybody has used a different definition for stroke and how they define strokes and how they define outcomes. So it makes it really hard to do a comparison for neurological risk across these clinical trials and some of the registries. Nonetheless, we know that LVAD type, female sex, AFib, and history of stroke prior to LVAD, hypertension, if you have an ongoing infection, history of pump thrombosis, and or GI bleed. All of these are risk factors for having a stroke. And of course, if you have high INR or low INRs, that could also be an issue and could lead to strokes. But it's truly the Achilles heel of our LVAD world, because, like I said, strokes are bad and they can really affect your outcome overall. So this is an 8th annual Intermax report, and this report is interesting and it's important to read, particularly as in the morning we will talk about how should we counsel our patients, and it really gives you all the details about the different adverse events. Of course, I'm going to focus on stroke. Of note, a couple of things about Intermax. It only captures FDA-approved data, so which means that if you're in a trial and the study, the LVAD or the device wasn't yet approved, Intermax is not going to capture that. And this Intermax report, which is the 8th report, is between June 2006 to December 2016. Generally, the rate of enrollment is continued at a steady pace, exceeding 2,500 implants per year. And there was a decrease that was noted in 2016, but it is thought to be related to increased enrollment in clinical trials. So like I said, it only includes FDA-approved devices, so if you're in a clinical trial, you're probably not going to be reflected in Intermax. Early after device implant, meaning within the first 30 to 60 days, why do people die? So people can die of multi-organ failure. They can die of right heart failure. And then, of course, our friend strokes. They pose the greatest risk within the early phase. And as you can see here, this is survival post-implant. And as you can see that this is general survival, that 1 month survival is 95% generally, 12 month 81%, 24, 70% for LVADs. Now, if you look at the causes of death and what portends a higher death rate in these patients, again, poor neurological outcomes or strokes are for the win. So they once you've had a neurological event, your survival decreases significantly. And that's true for if you look at the cumulative hazard. The cumulative hazard is the highest in the stroke category group. Now, why do patients after LVADs die? There are certain factors that are pre-LVAD, like for instance, age or their BMI or what their Intermax profile was. But this was interesting to look at, that for factors that affect survival post-LVAD. And 3 things stood out the most, and that one was presence of ascites, the hazard ratio being 1.73. If you're on inotropes immediately post-LVAD insertion, your hazard ratio is around 0.7. And then the number of strokes. So if you had a higher number of strokes, your hazard ratio is 1.47, and that was significant. So meaning that if you have a stroke, it's going to affect your survival post-LVAD, and we're talking about post-LVAD strokes. Now, going on to our first study, which is the intrapericardial left ventricular assist device, basically the HMDHVC study, the Endurance trial. So the Endurance initial trial was this new intrapericardial centrifugal flow device that they wanted to test against the axial flow device, which is our HeartMate 2 in patients who had advanced heart failure and who were ineligible for heart transplantation. This was a multi-center randomized trial, and it included 466 patients, and they were assigned in a 2-to-1 ratio to the centrifugal or the study device versus the axial flow or the control device. And patients who did not meet criteria for LVAD implantation were not eligible for the trial. The primary endpoint at 2 years was free from disabling stroke or device removal for malfunction or failure. And the trial was powered to show non-inferiority with a margin of about 15 percentage points. The analysis of the primary endpoint showed non-inferiority of the study device relative to the control device. Now remember, this is including device malfunction or failure. And it was 55.4% and 59.1% respectively. And this endpoint was driven more by the device malfunction or device failure. As you can remember, I mean, still HeartMate 2 patients have a lot more issues with device malfunction, device failure. So more patients in the control group than in the study group had device malfunction or device failure requiring replacement. 16% versus 8.8%. But more patients in the study group had strokes, so 29.7% versus 12.1%. I think that kind of took the heart failure world by a little surprise, because it was thought that once we have these newer generation devices, we would have less pump thrombosis and less device malfunctions, and by virtue of a better hemocompatibility profile of this newer device, less strokes, but it did not turn out to be the case. So they also kind of gauged the outcomes in success and failure. So failure was defined by death, device malfunction, if they had an exchange or an explant, or urgent transplantation was also categorized as failure. And then disabling stroke was categorized as failure. And as you can see in the study group, there were 3 patients, and percentage-wise 1%. But this is just disabling stroke, and we'll do the breakdown of the actual stroke rate and number of events in these patients, because it's always, when you're looking at these studies, it's important to look at all the supplemental data and go into the details as well, because a lot of important information is hidden in those. And there are a lot of times you realize that the stroke rate was actually not in favor of the study group. So if you look at the ischemic stroke burden, 17% in the study group and 8% in the control group. And if you look at the hemorrhagic stroke rate, it was 14% in the study group and 6% in the control group. So scary. And so then they kind of did. This is, again, an important breakdown in terms of, and again, this is supplemental data, so you don't see it in the actual study tables. So they talk about the study device versus control device stroke rate across the different time periods. So between 0 to 180 days, the stroke rate was higher in the study group. As we go along, it seems like generally the stroke rate decreases, and then we saw kind of more stroke perhaps in the long term. So in the long term, seems like maybe the study group had less stroke. Now, what does this tell us? And you'll see kind of a similar trend, that the stroke rate is actually the highest in the first 30 to 60 days, and then within a year. And after a year, it seems like, and especially after 2 years, it seems like the stroke rates drop. And in one of the trials, they went so far to say that in the Momentum trial, that the HeartMate 3 stroke after 2 years, the rate of stroke was similar to what you would expect in a heart failure patient. Now, that might be a little bit of an exaggeration, but that is what is a general trend. Now, this is important to understand from a study design perspective, because if you're going to design a study, maybe you want to target the area or the time period where you have the maximum number of strokes. So meaning that maybe within the first year and up to 2 years should be their follow-up to see what kind of stroke rates we're getting, thinking that after 2 years, the stroke rate might be much lower. If you look at the cumulative survival rate in patients who had HVAD versus control, the HVAD actually had, their survival was also lower versus the control group. Again, something that they did not quite account for, because the way the study was designed, the primary endpoint was looking at device malfunction and disabling strokes and device exchanges. But the survival was also much worse in the HVAD group. One thing I also want to point out, because this came up this morning, and going back to my previous slide, if you look at the GI bleed rate, that too, I mean, it was 35.1% in the study group and 34.2% in the control group. So by virtue of just looking at important hemocompatibility outcomes, which we talk a lot about in our current day and age, which includes strokes and GI bleeds, I at least wasn't sold on HVAD being a good hemocompatibility device just by looking at these numbers. Now, when we look at the causes of death in these patients in the study device group and the control group, the total number of patients that died in the study group were 116 out of 296, which is 39.2%, and it was 32.2% in the control group. And again, if you look at, you dichotomize these and see what were the reasons people died, again, 9.5% of these people died of neurological outcomes. So again, important, same point that, strokes are bad and they do take their lives and reduce their survival once they've had it. Now, then they tried to decipher further. I think they were a little bedazzled about why this happened, and looked into a little bit more detail. And it seemed like that perhaps if blood pressure had something to do with it. And they looked at the rate of ischemic and hemorrhagic stroke between the group that had greater than 90 millimeters of mercury blood pressure or not. And it certainly seemed that there was a higher propensity for stroke, particularly the hemorrhagic stroke in patients who had higher blood pressure. Now then, this second trial came along, which was the endurance supplemental trial, which the aim of this study was to prospectively see the impact of this blood pressure management on stroke rates in patients who had an HVAD device, because they thought maybe, we designed a good device. Why did it cause more issues? And so they thought maybe it's to do with the blood pressure, which was seen in a sub-analysis. So then they decided on doing it a prospective trial. And this was again a multi-center trial of 465 patients who were advanced heart failure, and they were ineligible for transplantation. One really important point to remember here is this is a DT trial. So when, again, if you're looking at all these trials and you compare endurance from, let's say, momentum, remember your study population is probably not the same, because you have patients with who are more destination therapy and endurance, whereas in momentum you have both DT and bridge to transplant. And as you all can know from looking at when we present people in our committee reviews, people who are eligible for transplantation are generally, in a sense, much healthier than those who are destination therapy. So this was randomized 2-to-1 HVAD. There were 308 patients, and again, the control group was 157 patients. And the primary endpoint was a 12-month incidence of TIA or stroke with residual deficit, 24 weeks post-event. So the primary endpoint, again, the details of that was the incidence of a neurological injury, which was defined as any stroke with a modified Rankin score greater than 0 at 24 weeks post-stroke, or any TIA or spinal cord infarct at 12 months. Then the secondary endpoint that they looked at was a composite of freedom from death, disabling stroke, meaning the MRS greater than or equal to 4, and a need for device replacement or urgent transplantation at 1 year from implantation. Again, another important thing is that this modified Rankin score is used differently in different studies. So again, that's something to look at when you're reading these studies. So in this study, the primary endpoint, unfortunately, which was, again, freedom from neurological injury at 12 months, was not achieved. And this is despite aggressive blood pressure control. The way the study was designed was that the control group, was just on autopilot, and everybody was allowed to do whatever they wanted to do with their blood pressure, and it was very institution-driven. Whereas in the device group, they were very meticulous about blood pressure. But despite the meticulous blood pressure control, it seemed that HVAD still did not appear to be non-inferior compared to the axial flow device. So not so hard to sell HVAD. The mortality rate, however, was similar between HVAD and control, so 16.9% versus 17.8%. And this time around, they did show the survival curves within the actual literature, so you don't have to go to the supplement like we had to go to the supplement in the initial endurance trial, where the mortality was higher with the HVAD group. A higher percentage of patients in the HeartMate 2 group experienced disabling stroke, meaning that they had the MRS score of greater than 4. Which was 1.6% versus 3.2%, and Device exchange was higher in the control group, 3.2 versus 10.2. Then again, strokes with MRS less than 4 were more common in the HVAD group, which is 9% versus 5.7%. So it seemed like while the HeartMate 2 group had generally less perhaps strokes than the HVAD group, they had a higher rate of disabling stroke. But again, at the end of the day, I belong to the group that thinks that any kind of stroke is bad. And even if they're saying it was not a disabling stroke, even MRS of 3 and 2 have their deficits. So, and it does eventually reduce survival. So for me, I still think that HVAD have a considerable risk of stroke. But again, if you're of the group that you think that experiencing disabling stroke is the worst thing that can happen to you, and then you can be a little bit of an optimist and say maybe HVAD is a better strategy. But at least this study did not completely address that issue. Now, if you look at the supplement data again, so if you look at scores of 0, 1, 2, or 3, these were higher in the HVAD group, and then the disabling strokes were higher in the HeartMate 2 group. And again, the mortality difference that was shown in this study was that HVAD, if you, in the best settings with excellent blood pressure control and good anticoagulation management, heartwares may have better survival than HeartMate 2 and have less disabling strokes. That's the take-home point from these two studies. This is just another depiction of how the stroke rate was distributed. If you look at this as well, so there is a good proportion of patients who had TIAs, 39% in the HVAD group versus only 25% in the control group. So again, those subclinical strokes or TIAs are still much higher in the HVAD. Now, so in conclusion, the endurance supplemental trial failed to demonstrate non-inferiority of the HVAD versus control, which was for the pre-specified endpoint of neurological outcomes. But one thing we learned from it is that the trial confirmed that blood pressure management is associated with reduced stroke rates in the HVAD subjects. So it's extremely important to have excellent blood pressure control. Of course, they also showed a little bit of a mortality benefit. This is again breakdown of all the strokes, 22.3% versus 16.9, ischemic 13.9 versus 13, hemorrhagic stroke 10 versus 5, and disabling stroke 8.1% 6.5, and TIAs 5.4% versus 4.2. Now comes HeartMate 3, and then this was tested against our HeartMate 2 again. So this was again a randomized trial in patients who had advanced heart failure. They either received the centrifugal flow pump or the axial flow pump. So this is different because here the denominator includes both the bridge to transplantation and DT patients, whereas in endurance it was predominantly DT patients. The composite primary endpoint was survival at 2 years, free of disabling stroke or reoperation to replace or remove a malfunctioning device. In the analysis of the primary endpoint, they defined disabling stroke as a modified Rankin score of greater than 3, and whereas in endurance, it was greater than 4. The principal secondary endpoint was pump replacement, because back in the day, there was this whole new article in NEJM where they talked about how the pump thrombosis rates have increased. And with HeartMate 2s, that was a real concern. The final analysis for this study included 1,028 patients, 516 in the centrifugal flow pump and 512 in the axial flow pump group. And in the analysis, the primary endpoint was reached in 397 patients, 76% in the HeartMate 3 group, and 64.8% in the HeartMate 2 group remained alive and free of the disabling stroke or reoperation or need to replace the device at 2 years. And in looking at the number of events per patient a year for stroke of any severity, major bleeding and GI bleeding were noted to be much lower in the HeartMate 3 group as compared to the HeartMate 2 group. So we'll look at that a little bit more in detail. So here, if you look at percentage of patients with event-free survival, HeartMate 3 was for the win, 74% versus 60.6%. And if you look at the breakdown of disabling strokes and death in this one, if you look at the centrifugal flow pump, which is our HeartMate 3, 550 patients, the number of patients that contributed to the primary endpoint, there were 20 disabling strokes and 80 deaths. And if you look at the axial flow pump, there were 505 patients and there were 30 disabling strokes and 67 deaths. So the epi for disabling strokes for HeartMate 3 was 0.04 and the epi for HeartMate 2 was 0.07. So this is the breakdown of the primary endpoint. Now, if you look at, again, the breakdown of pump thrombosis, number of patients in the HeartMate 3 group versus the axial flow pump, there's a big difference, right? So there's 7 versus 70. So truly, our HeartMate 2s are, the HeartMate 3 is much better for pump thrombosis, hands down. And if you look at any stroke, HeartMate 3 had lower strokes, 51, versus HeartMate 2, which is 98. So percentage difference was 9% versus 19.4 again. So leaning more towards centrifugal pumps are better. And bleeding wise too, it seemed like 43% versus 55%. And GI bleeding in particular, 24% versus 30%. So overall, it seems that, you know, maybe it has a, HeartMate 3s have a better profile. But there is a but to this, because while they talk about disabling strokes, the rates were better in HeartMate 3s. If you again look at the breakdown of other strokes, which will come down in my other slides, you'll see that that while there were less disabling strokes in HeartMate 3, the overall stroke profile still was significant in HeartMate 3 groups. Now, if you look at the number of strokes that people get are again higher in the beginning and the stroke rates decrease. This is, the blue line is for the HeartMate 3 group where you see the higher stroke rate at the beginning and then it trends down, and at 24 months, it kind of comes down to a level where it's the same as any regular heart failure patient. Now for HeartMate 2, the rate is higher in the beginning, then the stroke rates decrease, but then at 24 months, we see another increment of strokes. And why that happens, it could be any number of things, and it perhaps has to do with the longer you stay on the HeartMate 2, maybe your stroke risk increases, but the HeartMate 3 has a better profile. So in the long run, the stroke rate decreases, but what we need to focus on is what happens in the first year, and particularly in the first couple of months. Now, if you just look at the breakdown of other strokes, so non-disabling strokes and death. So non-disabling strokes in our, the rate in the HeartMate 3 group was 0.04 versus 0.11 in the axial flow. And then the disabling stroke 0.02 and 0.02, and death 0.02 and 0.05. So far, HeartMate 3 looked like it was doing much better than the HeartMate 2. Then came this analysis, which was analysis of the stroke in the long-term cohort of the Momentum 3. So they really break down everything about stroke. They kind of went over what the 2-year longitudinal assessment of stroke events, how would it impact the patient's life? So they would do a modified Rankin score at the beginning and towards the end. They also examined clinical correlates like, you know, very well, including baseline characteristics that particularly impact stroke events. And in the long run, how do these neurological deficits affect patients? So in this one, then focusing just specifically on HeartMate 3 and HeartMate 2 strokes, there were 65 strokes in 52 patients at a median of 131 days after implantation. And the majority of the strokes in this study was ischemic, 40 versus 25 hemorrhagic strokes. The overall prevalence of strokes at 2 years was much lower in the HeartMate 3 group that we could see in the Momentum trial. All the graphs made it look like the overall prevalence was lower in HeartMate 3 versus the HeartMate 2 group, 10% versus 19.2%. And this included, both ischemic and hemorrhagic strokes were lower in the HeartMate 3 group. However, with the hemorrhagic stroke, it did not reach clinical significance, this difference. With respect to the severity of the neurological impairment, they did not observe a difference between HeartMate 3 and HeartMate 2 when all disabling strokes were assessed. So that's an important point to remember, including the first and recurrent stroke events at their initial presentation. So 8.4 versus 8.1%. After they did a reassessment of the MRS score at 60 days. So non-disabling strokes were reduced in HeartMate 3 compared to HeartMate 2 group, which was 2.1% versus 14.5%. But the disabling stroke rate was not much different. So again, if you belong to a group that thinks that any stroke is bad, then the stroke rate overall was lower in the HeartMate 3 group. But if you're in the category where you make a case of a disabling stroke being a bad thing, and you don't care much about the non-disabling strokes, then HeartMate 3 still had a rate that was similar to HeartMate 2 for disabling strokes. However, and this was in the initial phase, and over a period of time, the stroke rate eventually tapered down for HeartMate 2, whereas we did see, for HeartMate 3, sorry, and we did see an increment for HeartMate 2 strokes after the 2-year time. So if you look at the disabling strokes, if you're a person who follows curves more accurately, then if you look at the 60-day modified Rankin score, the disabling and stroke rate was similar, sort of, but the non-disabling stroke is where the HeartMate 3 really was for the win. And if you look at the stroke severity at initial presentation, then HeartMate 3 had similar type of presentation as opposed to HeartMate 2. But if you look at the non-disabling strokes, you could see that there's a remarkable difference between HeartMate 3 and HeartMate 2. So in essence, non-disabling strokes are less in HeartMate 3. The disabling stroke rate is similar, and the severity of the disabling stroke is similar in the two devices. But overall stroke rates are for the win in HeartMate 3. Now, this is a table which goes over stroke events and other neurological events. So one thing that I thought was interesting, first stroke disabling at presentation, if you look at when the stroke would occur, there were higher number of patients in the HeartMate 3 group that had stroke that was disabling, more disabling compared to the HeartMate 2 group, which was 8 patients. I mean, these are small numbers, so can't extrapolate much from it, but it just kind of gives you a hint towards what HeartMate 3 hematocompatibility is like. And maybe in the initial phase, the hematocompatibility is worse compared to the follow-up phase. Then if you look at first stroke non-disabling at 60 days, the rates were much lower in the HeartMate 3 group, 7 versus 26. Now, coming down, one other important thing that I wanted to mention here is that in these patients who are in this trial, they had set another category, which was other neurological events. And this included encephalopathy, seizure, or other neurological events, like somebody fell and had a subdural hematoma. So they were categorized separately, whereas in the endurance trial, they were all put together in the same neurological outcomes category. So whether that has to do with how their outcomes look, that is still not known, because of course we don't have a direct comparison of HVAD versus HeartMate 3. But this is also an important consideration, because the N changes because of this, if you're looking at just overall neurological outcomes, because endurance included this overall neurological outcomes in the study. So this is again a momentum secondary analysis, and if you look at the timing of stroke, perioperative, short term, long term, it seems like HeartMate 3s generally again have earlier strokes, and long term strokes are much lower compared to HeartMate 2, and in the long term, HeartMate 2 has higher stroke rate. This is again a comparison of similar disabling versus non-disabling over 30 days and 31 to 180 days, and then 181 to 730 days for HeartMate 3. And again, as you can clearly see, the rate of non-disabling and disabling strokes. So the disabling strokes are much higher in the HeartMate 3 group in the initial phase, and as we go along the way, the rate decreases. Whereas in HeartMate 2, it predominantly are non-disabling strokes in the first 0 to 30 days, and they have a lot more non-disabling strokes compared to the HeartMate 3, but the disabling stroke rate is lower compared to HeartMate 3. And this is a breakdown of ischemic versus hemorrhagic. So a lot of HeartMate 3 initial 30 days are ischemic, whereas in HeartMate 2, ischemic strokes are still for the win, but there is a lower rate, there is a relatively high rate of hemorrhagic stroke compared to HeartMate 3 in the 0 to 30 days. Again, one thing just that I mentioned earlier was the survival post-implant. Consistently, if you have any type of stroke, whether you have hemorrhagic or ischemic, or you had disabling versus non-disabling, whether you had a modified Rankin score of 0 to 4 or 5, your survival is going to get worse compared to baseline, compared to somebody who did not have a stroke, clearly, and all across the board. So again, just take home point, strokes are bad and survival is reduced in patients who had strokes. Now, this was the UK registry. I thought it was interesting to read what they do differently. So they had patients who had HeartMate 2 or HVAD. They do not do DTs in UK. They're not funded. And they looked at their database across 2013 to November 2015. And what they thought was their 30-day survival rate post-implant was 88.9%, while the overall patient survival at 3 years was 49.6%. So this is a lot lower than the United States. And of course, I don't know how they're different than us, but it clearly seems that their survival rate is much lower than us. And again, in their population too, the most common cause of death was a cerebrovascular accident, which was 28 patients died following an ischemic stroke, while 24 patients died after hemorrhagic stroke. And only 25% of their population underwent transplantation. And that also is much lower, given that this was all BTT. Again, just the breakdown of what their stroke rate looks like. So if you look at their event count between HeartMate 2 and HVAD, stroke, their event count was 23, and their event rate per 100 patients was 1.04. And in the HVAD group, they had 62 events, and their event rate was 1.26%. And their rate of ischemic and non-ischemic stroke was lower in the HeartMate 2 group and, as opposed to HVAD. So go figure, because I do think that if you have registry data, it kind of reflects what happens day to day in our lives, and again, because you're not following strict protocols and everyone's, it's real life data, so to speak. Whether we want to extrapolate from that or not, but this did show worse stroke profile in the HVAD group, way worse than ours, but still in our US data too. I mean, HVADs did perform worse than HeartMate 2 in the stroke arena. And if you look at their stroke rate versus the Intermax registry. In our registry, it accounts for 18% of deaths whereas in their registry it accounted for 34% of deaths. So this had an important insight because they thought because they had much lower transplant rates and longer device support time with these devices, and patients are dying of strokes, most notably, it could have important implications in the trajectory of an LVAD patients. Meaning that in the current system, if somebody has a stroke, whether or not our system should give them precedence for transplantation, even if they had something simple like a TIA, because it portends poor prognosis, could be something that could be considered. And I think that's a very important thought for our leaders in heart failure to think about stroke as a sentinel event, and that if patient has a stroke, they should be higher up on the list. So moving on to the lateral trier. So lateral trier is an evaluation of a lateral thoracotomy implant approach for basically the HVADs. This was again a multi-center trial. It was non-randomized, and it was a single-arm trial, which included 144 patients. And the primary composite endpoint was success at 180 days, which was defined as one, you're alive on the originally implanted device, and you're free from disabling stroke, again defined as modified Rankin score greater than 3, or you transplanted or explanted for recovery. That was defined as success. And the key secondary endpoint was the length of stay. If they had a body surface area that was less than 1.2 meters squares, they were not enrolled in the studies, or if they'd had prior surgeries, or they had severe right heart failure, because in case you needed to put in RVAD, or if they had a concurrent surgery that was planned, they were not candidates for lateral. Now, they had, as I mentioned, 144 patients enrolled. The primary endpoint, again, if you're alive, if you're transplanted or you explanted for recovery, was achieved in 88.1% of the subjects. And if you look at the original trials, this 88.1% was actually much higher than the original performance of this device, which was 77.5%. And interestingly enough, if you look at their stroke rate, strokes with modified Rankin score greater than or equal to 4 were much lower, 2.8%. So, and the secondary endpoint, of course, they also showed that their length of stay was much lower in the lateral trial. But just if looking at stroke, overall stroke rates were much lower. And the rate actually decreased even further as we went along further. Just the same philosophy that as the time increases, in the initial phases, the more strokes that you see, and then as you go along, months since implant, 6 months, you have 91%, and at 12 months, it's 87%. And again, the same held true for time to disabling stroke. Freedom from a disabling stroke was 100, 98%, 98%. So this is beautiful data if you look at it from a stroke perspective. And again, why would that be? Lateral was again a study that was more towards geared towards bridge to transplantation. 1 and 2. The other important part is that, of course, patients who are bridge usually are much healthier, as I mentioned earlier. The other important thing is, of course, this is not it's a non-randomized. It wasn't over, it wasn't a randomized trial. But also, if you look at chronologically, I've gone over all these studies in a chronological fashion. So endurance was first, and lateral came down the line. So as we are, getting better with device technology, we ourselves improve in taking care of these patients. So the thought is that maybe we're also getting better in taking care of these patients and understanding strokes a little bit better, and therefore the stroke rate is also declining over a period of time. But I mean, this is again too much extrapolation. I don't want to extrapolate too much, because I still think that we still have to learn a lot about strokes. So Then, of course, frustratingly enough, there is no trial to compare all three devices, which have been very nice and convenient. But there was this a study that was done by Meher et al. And what they looked at was they compared the event rates of HeartMate 2, HeartMate 3, and HVAD, and they looked at all these registries and trials and looked at their patient selection criteria and treatment protocols and adverse events. It's a good read because it kind of really gives you an insight on how to think about this, because we have so much confusing data and you have to really go into the supplements to understand each trial really well. So, and they realized that, of course, there are so much inconsistencies in exclusion criteria and patient selection and treatment protocols and adverse event definition that, you really can't compare them. And there's not a single best metric to measure and compare the risk. And one other important thing, of course, is not all strokes are equal, fatal or disabling or neurological events like TIAs, whether they're equal or not. So they looked at all these trials and they looked at their follow-up period and they also looked at their implant indication. I've kind of gone over most of this as I've gone over all the studies, but importantly, one thing I wanted to mention is the HeartMate 3 CE mark, which was the original study that was done in 2014. Their stroke rate was also much higher than the Momentum 3. And then again, that has to do with how the study was designed and how the protocols were done. And also there's a thought that since how the neurological outcomes were redesignated in the Momentum 3 trial, that may have something to do with it. Again, endurance supplemental that was looking at HVADs was predominantly a DT study, lateral 100% DTT, and then of course, registry. And they recommended that the best way to kind of talk about stroke is event per patient format, because if you talk about percentages, the N or the denominator is not the same across all these studies. So in this, analysis, if you look at all strokes, this is looking at 2 years. And if you look at the Advance and UK and Intermax, they're less than a year, so you can't really compare them with all the other studies. And if you look at the total neurological events, it was the highest in the endurance supplemental and the lowest in the lateral. We're at one point saying that HVAD is terrible because it performed really bad in the endurance supplement and it was even not good against HeartMate 2. But in the lateral, the stroke rate was so much lower. Of course, it was not a comparative study, but that's something to keep in mind. And if you look at the overall stroke rate also, in lateral was the lowest and the highest was the endurance. So definitely kind of points towards that there is something to be said about the study population, something to be said about the DT population versus BTT population. Again, ischemic strokes were also highest in the endurance, lowest in the UK registry. So then, again, the same point, the endurance supplemental had the oldest population with the highest percentage of patients with ischemic etiology, history of atrial fibrillation, and history of stroke, which all portend a high risk of stroke in the future. And the lateral, the Advance, and the UK registry had the youngest and the lowest risk of baseline stroke rates. So, and again, one other important thing is that while we are comparing neurological events here, they had all used different definitions of neurological events. And I think that I went over again before. The rate of stroke for HeartMate 3 was almost half in the Momentum 3 compared to the original HeartMate 3 CE mark trial. And HVAD had a stroke rate of 0.1 epi in the lateral compared to 0.23 in the endurance supplemental trial. And for both HeartMate 3 and HVAD, the best neurological events or outcomes were achieved in the most recent trial of the device. So if you look at all three VAD platforms, HeartMate 3 had the lowest stroke rate achieved in the Momentum 3, whereas HVAD had the lowest disabling stroke rate and total neurological event rate, both achieved in the lateral trial. So if you look at overall all these studies, if you had ischemic etiology or you had AFib and history of prior stroke, your rate of stroke did increase. So 3 important baseline characteristics to look at. And this here is looking at basically what their intermax profile was, the age of these patients, how many of them had ischemic etiology and history of AFib. And if you look at proportion of disabling versus non-disabling strokes in the HeartMate-3 and HVAD, so HeartMate-3 in the Momentum trial had 50-50, whereas HVAD in the lateral trial, the disabling stroke rate was 30% versus 70%. Whereas in the Endurance Supplemental 2, the kind of proportion was similar. If you look at the pie chart here, 22% disabling versus 78% non-disabling stroke. Now, if you look at the overall freedom from disabling stroke at 1 year for all these trials and all these devices, the worst performing was our HeartMate-3 in the original CE mark trial, where their rate freedom from disabling stroke at 1 year was 84.9, and at 2 year was 77.3. However, in the Momentum 3 trial, it was 93 versus 92.5%. And the best performing was the lateral HVAD trial at 1 year, 97.9% versus at 2 years, 95%. And why would that be? Again, it has to do with their patient population, the N, and their exclusion. So I don't think that anyone at this point in time can we surely say that anyone is consistently better in neurological outcomes metrics, because when we started thinking that in the Momentum era and at the 2 year mark too, you could convince yourself that HeartMate-3s are much better. And I do think that HeartMate-3s do have a better profile. But as you move along, you look at the lateral trial, you have to pause for a minute. You can't let that go, that their outcomes were so much better. I don't know if as a you know, the patient population and the centers that were involved in that study did an excellent job. That I can't speak of. But for sure, it makes you pause and think that maybe we should not completely get rid of HVAD at the moment. Again, one of the important things is that in the beginning, HeartMate-3s still have a higher proportion of disabling strokes. I think I've talked about most of these things. Now, this was an interesting way to do the study, because I think these are people who got frustrated, much like me, that there's no direct comparison between HVAD and HeartMate-3. So they tried to do this hybridization technique. And what they did really was they combined BTT population of HVADs with endurance, which is the DT population. They also excluded cardiogenic shock, because they said if you really want to compare this study population of HVAD versus the Momentum trial, Momentum did exclude cardiogenic shock patients. So they excluded the cardiogenic shock patients, and they took patients from the BTT trial and combined them with the DT patients and made this hybrid population. You know, for some people who are sticklers for statistics and would argue that this is probably not the right way to do things, but you know, this probably gives us some insight. And in this, they saw that at 6 months, the rate of strokes in HVAD was 14.1% versus 13.9%. And at 2 years, it was a little higher, 23.3 versus 21.7%. And if you look at freedom from disabling stroke or percent survival from a major stroke, it looks like they are comparable. However, and even you could say that that HVAD had better survival. I mean, it gives us some insight, but I don't think we can completely extrapolate from this. But it surely tells us that if you had apples and apples and you had compared similar outcomes and the N was similar, meaning that your total denominator is in the HVAD and the HeartMate-3 group, makes sense. And if you do a comparison, you might end up with something like this. Of course, again, as I said, this is just an over extrapolation, but something to think about. So I guess I'm almost towards the end, but these are some of the further research questions that I kind of am interested in. You know, device type and implant technique, if that makes a difference, as was suggested in the lateral. Should we have a risk scoring system for expected stroke for patients with LVAD who are BTT, and we should prioritize them more on the transplant list? And does lateral thoracotomy give a better profile for aorta exposure? Does it have to do with anything with angulation? And then, endovascular treatments. I didn't find a whole lot on this being published. And we kind of looked at this outflow canal anatomy in these patients, and this was predominantly HeartMate 2 technique, population. And we did see that the outflow angle relative to the ascending aorta and the area of anastomosis, which is actually this area where the outflow graft enters the aorta, is correlated with strokes. And this is some of our curves. So if you had a diameter greater than 1.5, you clearly see a big, there's more stroke-free survival. And if you had an outflow canal angle that is greater than 37.5%, that also had more stroke-free survival. So with this, I'm going to end. I know I'm above time. If there's any questions, I'm happy to answer.
So do you think, is it time for, maybe somebody in either you or anybody else to actually look at the INTERMACS registry data, but include both surgical, because I think many people are doing lateral thoracotomy now. I mean, it's not, at least you will have a decent N where you could potentially include the surgical technique and also the device type, because, it's been about 3 years now or 2 years now that HeartMate 3 has been approved. So we should have enough N. And I think, it would be time for, I think we should, because I think what would be nice is for a given patient to be able to figure out the device type, right? I think we can. So I think if you want to say, okay, you're a 20-year-old guy getting an LVAD, which one's better for you, and versus a 70-year-old with stroke. So I think hopefully somebody, will do like that for us, and
Yeah, almost.
What is that?
I feel like it's almost like a scoring system, So if you're 20
Correct. No, that's what I'm saying. Exactly. No, that's what I was getting to. And you can easily do that with a multivariate analysis. So, look, we are part of INTERMACS. We've given them a lot of data, but not even done one analysis. So this is a, opportunity, because especially with Tom being STS. So I think, you should see if you can do that, because I think that would really be helpful.
Yeah, because I feel like, when we compare surgical techniques, I don't think you can just do it as a single center, because we, of course, know that.
No, we can. No, that's why I'm saying I think INTERMACS is right for it, because I think now we have enough patients to do it.
Yeah.
See, because the clinical trial data doesn't go into INTERMACS, and that's the problem.
Yeah.
So, if you were to look at HeartMate 3 versus HVAD before, it's kind of too early, but now we have enough. So I would suggest, it's an easy thing. They'll provide you the statistician and everything. If you can push with Tom, I think we should do it, because we've provided enough data to them, and to not be able to use the data.
Intelligent way to kind of look at the stroke outcomes also, because as you can see, there's so much discrepancy. I feel like that's
and all of this will come in, right? I mean, if you are on an Impala and going, then maybe HeartMate 3 is better, but if you're walking in from home and everything's okay, then maybe it's not. So
and I think they have all this data, so we can definitely look at
Thank you for this talk.
Okay, if there are no further questions, then we can end the talk. And thank you so much for everyone for attending. Thank you.